for that very kind introduction, Rayanne, and thank you for inviting me to be here. Can everybody hear me okay? Yeah, it's okay. All right. And I want to acknowledge Missouri Breaks and Avera for hosting this symposium. And it's just really great to be here. Last time I was out in Rapid City was years ago when I worked for Indian Health Service, and we had to we came out to engage with the tribes and engage in discussion about how we can improve our healthcare services that we deliver through IHS. So it was a great meeting, got lots of great feedback, good dialogue, good discussion. One thing about the Great Plains is their folks aren't afraid to share their opinions and be good advocates for their people. And we appreciate that. So again, thank you, Rayanne, for having me here, and thank you for the ride here this morning, Marcia. She sent a limousine to bring me here. I was quite impressed. But we did have a great chat coming in, so thank you for that. So the title of my talk is a little bit different than what I shared on the agenda, and it's strengthening tribal health research and moving forward at the speed of trust. And this is forward. Yeah. I'm kind of old school, so I don't sound like her. So the speed of trust is an important concept. It came up recently. One of my colleagues quoted Stephen Covey, but I first heard it from Dr. Griffin Rogers. He's the Institute Director for the National Institute of Diabetes and Digestive and Kidney Diseases at National Institutes of Health. We were meeting with Pasco Yaqui tribe down near Tucson, Arizona, and this concept came up. It was just, we wanted to move forward, and I think one of the participants there said, but we have to trust you. And Griffin said, yeah, that's the way we have to move forward. It's moving forward at the speed of trust. Because we're not going to get ahead of ourselves. We need to establish that partnership, that relationship, that trust, and then we can move forward together. And that's been our philosophy at the Tribal Health Research Office, and that's the way we're moving forward. And that's how we're advising senior leadership at National Institutes of Health to move forward. We need to invest the time to understand communities and context underlying health, worldviews, holistic approaches to health, honesty and transparency in tribal health research partners, and recognition of value of traditional knowledge, indigenous knowledge, and tribal lived experiences. Respect, true partnership, equity, capacity build. So I'll get into each of these concepts and as I go through my talk today. I feel like moving this over to the corner. First, we have to acknowledge history. Right? One of the theft is one of the overriding experiences of Native people since first contact. And theft included land, sovereignty, family members, language, culture, religion, knowledge, religious and cultural artifacts, native symbols, ancestral remains, and more. It's important to acknowledge that before we move forward, or as we move forward. Along with theft of many aspects of Native existence, loss and historical trauma have been pervasive, and we know that. There are researchers in this room who study historical loss and historical trauma. So that's something we need to acknowledge. Another important thing that's happening right now are changes in the social landscape, right? So there was the statement issued, or there was a memorandum issued by the administration, President Biden, in January of 21, that talked about the priority of administration to respect tribal sovereignty and self-governance, commitment to fulfilling trust and treaty responsibilities to tribal nations, and regular, meaningful, robust consultation with tribal nations. It's the cornerstone of federal Indian policy, so that's what we've been doing, and I'll get to a couple of things that we've been working on, and things that we've rolled out and accomplished in a very short period of time. I've been with the NIH for about 5 months. So I came from, as Rayanne said, I was a CEO for the Hopi Healthcare Center, which is a critical access hospital in the northeast of Arizona. So 5 months, I'm still learning all the acronyms. I don't know if I could be with NIH for 20 years, still not learn all the acronyms of all of the institutes and centers and others' offices. It's just information overload. So I'm trying to get up to speed on all that. But at the same time, we're rolling out programs. We're working on initiatives, and I'll get to that today too. But these social changes in the social landscape are the backdrop that we're trying to get this work done in. But we all, we have a social landscape, but we still have that government-to-government relationship between the federal government and tribes, right? So I think we have to acknowledge that. And a lot of what we do is educating our federal partners on that government-to-government relationship. A lot of times our partners say, well, consider American Indian Alaska Natives as another minority population or underrepresented population. And we have to remind them that there's a government-government relationship there. So the programs that are set up through Indian Health Service, Bureau of Indian Affairs, those are all due to that special relationship. And I'm surprised that a lot of folks in federal government still don't understand that. But we make every opportunity and take every opportunity to share that information and to educate them on that point. Also, the diversity of tribes. A lot of folks, think of American Indian Alaska Natives as one homogeneous group, and we have to educate them on the wide diversity of the 574 federally recognized tribes, as well as those tribes that aren't federally recognized, right? So that's a lot of what we do with the education and working with our partners, because if we're working with institute and center directors and staff in those ICs, it's important for them to understand why we're doing what we're doing. Reinforced commitment to tribal. Okay, just want to make sure. And government-to-government relationship. So there was a memorandum issued by President Biden in January of 21. And it's basically it reinforces another memorandum, which reinforces Executive Order 13175, which was enacted during the Clinton administration. So each succeeding administration has issued memoranda to say again what needs to be done under that executive order. So it's really about engaging tribes in a meaningful and constructive way. Any policy decisions at the federal level that may affect tribes in a substantial way. So that's. I know that sounds really boring, doesn't it? A lot of stuff we do in policy work at the federal level is really boring. And a lot of folks don't like to, they're just like, well, I don't want to do that. But it really has lasting, meaningful impact. And those of us that do it, I don't know why we do it. But it has lasting impact, right? But it's tough at times because we really have to kind of slog through all of this kind of administrative and other types of work to get to the point where we actually issue a policy. And it's, you think passing a law is that when we talk about policies in some of the federal agencies, and it takes a lot of work and it takes a lot of engagement, dialogue, discussion, negotiation, and eventually you get a policy that you think is a good policy. But you always revisit that work because things change, right? And you have to update policies to make sure that they're still relevant. So, or they still do what you intended them to do. So those memoranda are what we're following now. Just as an example, I don't know if y'all see the Indigenous traditional ecological knowledge consultations that have been going on. Anybody seen those or participated in those? Oh gosh, we have to do more work in getting that up to the field. Well, we've had 2 consultations. We've had 1 listening session. The White House is really again, there's another memorandum that they pushed out on traditional ecological knowledge. And it's dealing a lot with indigenous knowledge, traditional knowledge, and it's requiring federal agencies to consider that as they do their policy work. So how are these regulations, how are these policies going to affect tribes? And can we use traditional knowledge or engage with tribes to share that knowledge with us so that we can come up with policies that take that into account? We all know that there are indigenous nations all over the world that have sacred knowledge of the environment, of many different aspects of life. Right? And those are important to consider when we're making policy, when we're making regulations. So President Biden has ordered all federal departments to do that. So we've been having, let me make sure I get this right. We have 5 working groups that are on this. We have an interagency working group. I know when we do stuff in the federal government, what do? We form working groups, we form committees and subcommittees, right? But no, we're actually making a lot of good progress on this work. 5 working groups are working on different aspects of policy development. And there's an interagency working group that's over all of this, that's coordinating all these functions. So we've heard a lot from tribes. We've heard a lot from the medicine people of different tribes that have been very, very eloquent in how they're trying to educate federal agencies as we move forward. So that's one of the examples of really good consultation and getting really good feedback as we develop policy. So here, just wanted to share, this is the NIH, right? This is Department of Health and Human Services. The NIH is just one operating division, it's called, in the Health and Human Services. So these are all our partners. So that's how I view this. I see SAMHSA as a partner. I see Indian Health Service as a partner, CDC. We've seen that during the COVID pandemic as well, right? So the healthcare, everybody came together. I've worked with the CDC before on H1N1 when I was the public health director, and they're great to work with. So what we try to do is work with our sister agencies on all these cross-cutting issues that affect tribes. We even work within the NIH. As I mentioned, there's 27 institutes and centers that we work with, and they're all different. They all have different cultures. So we try to bridge that, and we try to work with different ICOs, as they're called, institutes, centers, and offices, to try to move things forward, effectuate our strategic plan, and try to get some work done that helps move things along in tribal health research. And consultation is a big part of that. So NIH, our mission is to seek the fundamental knowledge about the nature and behavior of living systems and apply that knowledge to enhance health, lengthen life, reduce illness and disability. The function of the NIH Tribal Health Research Office.
Some help.
Can you advance it?
Mm-hmm.
One more.
Okay.
Okay. So this was a strategic plan that was rolled out for fiscal years 2019 and 23. One of my jobs right now is to evaluate the strategic plan. So what I've done is reached out to all the ICs and ICOs, give me information on what they've done to support the strategic plan over the last 5 years. So I got 562 activities so far, in excess of $300 million. So that it just demonstrates all the different activities that are going on, all the different resources, the amount of resources that have been put behind research with American and Alaska Native communities. And what I'm trying to do is kind of sift through all this information, pull out some themes, and put together a report that we'll then take to our tribal advisory committee to share it with them, and also to tribes through consultation, and get feedback on, okay, where do we go next? This was our plan. This is what we've accomplished so far, and what needs to be revised, what can be changed, what needs to be added, deleted, and so that we can keep moving forward. So that's what we're working. One of the things that I'm working on now. So as I mentioned, we also work with the ICOs. So we're working with all these different acronyms. NCATS, LBI, NIEID, Aldo, Dr. Fauci, and DDK, I mentioned Dr. Rogers. NIGMS is I don't know if any NARCH recipients, NARCH grant, NARCH awards. I was the project officer for the NARCH program too, for Indian Health Service when I was at headquarters. So I thought I might see some familiar faces in the room. So NIGMS is, they put a lot of resources behind development, capacity building, basic science funding. NIHD is another big supporter of the National Institute of Minority Health and Health Disparities and the National Institute of Neurological Disorders and Stroke. So we work with all these different ICOs to try to move things forward. So as I mentioned, there's a portfolio analysis that was done in FY18. We're doing another one now, and it looks like the numbers are a little bit more than what we anticipated back then. So even more resources are being put behind American Indian Alaska Native research. So we're happy about that. Of course, we can always do more, and that's what we continue to do. Over 500 different areas of activity, and hopefully more soon. So this is the strategic plan that we're evaluating currently, FY19 through 23, and the goal is to improve our relationships and collaborative efforts with American Indian Alaska Native communities. Now that some of the travel restrictions are being lifted and we're able to travel, I'm here. This is great. We're also traveling out to the communities. And as I mentioned, we went down to Tucson. It wasn't too far for me because I'm stationed out there in Arizona. So it was just a 4-hour drive down for me. But, we engaged with a Pascagoula tribe. We engaged with the Tohono O'odham and Hopi tribe. Drove all the way down from Second Mesa. They met with us. So it's really engaging with the tribes and finding out what the needs are. And we're getting a lot of good information. I mean, we're getting information about how to help. I know one medical officer brought up the fact that he had 2 single moms that needed to go to school, but they didn't have the support to do it. And he was asking NIH, is there a way that you guys can work with other agencies to figure out how to support these single moms as they get their degrees? And because he was saying, well, they'll stay in the community. And it's really, I don't know if y'all know, but it's hard to recruit care providers out there right now. And these NPs, RNs across the board. So he said, but if we can get these through and get these 2 young ladies to go through and get their degrees, and they're going to stay in the community, they can be here for 20 years. So we're an investment that would be. So it was a great point. That was what we took back to figure out, or wrap our heads around and see what we could do. And that's just one example. We're having lots of good conversations with tribes, and our leadership is hearing it from the tribal leaders themselves and not from us. So I think it has a lot more impact coming from those leaders and those people in the communities who live with it. So our guiding principles: respect, transparency, and communication. Respect is a big thing that we hear a lot too, from community members and leadership. Respect for sovereignty, respect for tribal IRBs. There are over 50 tribal IRBs out there, and we're actually doing some work to help support them. And there'll be more rolling out in the coming months and years. It takes a while to get some of these things done. For anybody that's applied for an NIH grant knows what I'm talking about. A lot of work goes into those funding opportunity announcements, and I've learned a lot about that lately. Gosh, a lot of work goes into it, and a lot of back and forth. Transparency, being open, authentic, and real. It's one of the best quotes I ever heard or definitions about integrity is just being your word, just being honest. I'll tell you what I can do, and I'll tell you what I can't do. And that's kind of how we're approaching everything with our relationships and our engagements. And communication, be sure to communicate in culturally appropriate ways. Community-based participatory research, that's something I say 20 times a day to folks. We really need to be mindful of that. And we really need to somehow work to codify that in regulations and policy. It just makes sense on so many different levels, and it's the right thing to do. We just rolled out a new consultation policy too. We were working off the departmental HHS policy, but now we rolled out an NIH consultation policy. And it includes definitions, objectives, descriptions, details, reporting requirements, evaluations, and regular assessment. We have a tribal advisory committee who are very active. They're great. They provide good feedback. They're great partners. But we also do a lot of consultation. And I'll get into that next. Multitasking. So I'm not sure if anybody here participated in the N3C consultation that occurred a month or two ago. That is the community-driven initiative that's important, that allows research teams nationwide to look at questions about COVID-19, risk and protective factors. My mantra for the last 12 years has been, we need to get away from the risk factors and look more at protective factors. And it's good. That's what we're hearing from the communities too. We need to be thinking about resilience, protective factors, rather than always just ease and risk factors. Right? So this is a good thing. And also medications that may mitigate or promote severe infection from COVID and long-term effects. We heard a lot of long COVID concerns from tribes, and we're working to include them on the work going forward. Okay, you've all heard of the HEAL initiative, the Helping to End Addiction Long-Term initiative. All right, I can see that we have to do a lot more outreach in the Great Plains area. We had a couple of consultations on HEAL. I think it was two. It was just one. Again, I've been with NIH 5 months, so I can only speak what's happened since I've been. So HEAL is a trans agency effort, and this is run out of the office of the director. And I should point out too, the Tribal Health Research Office is in the office of the director at NIH. It's not buried in some institute or center, across the agency. It's right in the office of the director. So my chain of command goes to Dr. Wilson, to Dr. Anderson, and Dr. Tabak, who's the acting NIH director. And I thought that really sent a statement that that's the importance of what we're talking about here. This office is situated right in the office of the director. So we have that reporting hierarchy, and we have that, you have the bully pulpit, right? That's basically what it comes down to. And we have that, we have the strength and support of Dr. Tabak behind us when we approach other institutes and centers. So it's a really good thing to have. And it gets people to the table to start talking. So the consultation on HEAL, that was in March of this year. And we got a lot of really good feedback on that. We all know the challenges of opioids in Indian country. And we were working with our federal partners, like I mentioned, with Indian Health Service, with some of the other agencies, SAMHSA, CDC, and others on this. So with the HEAL initiative, that's for prevention research, basic and translational clinical trials, and implementation. science. There's over 600 programs across NIH, 26 research programs, and projects underway in all 50 states, and released over 50 funding announcements since inception. So that's another example of how we're engaging. Data sharing and management. This has been a really important issue lately. Tribes are very concerned about data sharing, especially when we talk about electronic health records. Obviously, those are pretty sensitive data. We have some partners that are doing some really good things around this. We have some template agreements that we've shared with some folks that are interested in that. And some of the funding opportunity announcements that have come out from NIH, data sharing has been a component of that. The most recent was a consultation on RADx Up, Tribal Data Repository. Everybody participate in that one? Yes. Thank you. We didn't share it with everybody else here, so thank you. I really appreciate that. So that was that's going to be it's sovereignty-based governance structure. So the tribal data repository of those grantees that are receiving RADx Up funds, they put out an announcement that they're looking for one entity to oversee this tribal data repository. So long COVID and all those COVID concerns, that's going to be really important, and it's going to be tribally controlled. So we're providing some assistance there. They did the consultation, and we're going to be moving forward on that. Did it change? Turned up really high. I honestly don't know how loud I am. Another important thing we're working on is ethical inclusion of urban Indian populations. Biomedical research, we all know that 70%. Give or take, American and Alaska Natives live in urban settings, right? I'm an urban Indian, right? I don't live on my res anymore. I live closer to Phoenix, so I guess I'm urban. So we're taking a look at this too, and because some tribes express concerns around their tribal members in urban areas that are being targeted for certain research studies, and we want to make sure that that's being done in an ethical and responsible way. And we're working with our TAC on that to develop a framework and guidance. So that, and there were 2 publications that came out from that. One, we worked with a tribal IRB. It was co-authored by the tribal IRB and our staff, and we put that out and published that. So that's there if you ever want to read it, if you haven't read it already. Communications clear, culturally appropriate, and responsive. So during COVID, we developed a lot of these materials. Up at Hopi, we also developed some culturally appropriate education materials for the community. And on the Hopi reservation, there are a lot of really talented artists. So they were able to put together some really cool communications materials that we put out. And a coloring book, like the great coloring book that we shared with you this morning. So it's really cool when you get a product like that you can share with the community, that they understand, and it's culturally appropriate. I mean, it's just amazing the different products that you can develop, working with tribes. So, and this one, hang in there. I think that was developed with Johns Hopkins Center for American Indian Health. So there are a lot of good things going on. Probably a lot of you participated in these two. The interviews with Josh, Dr. Josh Gordon, and the interview with Nora Volkoff of NIDA. These were really well received. They were great information. Tribes, the participation was really great. responding to the interests of tribal communities, increasing interest from other ICs about outreach to tribes. We get dozens of messages from other institutes and centers across NIH every week to help them do the outreach now. And I can tell you, 7, 8 years ago, we weren't getting them. So a lot more institutes and centers are reaching out to get that advice, to get that help, that assistance. And things are really changing. We're victims of our own popularity because we just can't field all the requests and do everything that we need to do. So we're working on. I keep asking Dr. Wilson to hire some more people to help us out because it's a lot of work, and that's the thing. And with the tribal advisory committees too, now with the Biden administration's memo coming out that they have to do consultation, well, tribal leaders are dealing with about 100 different things every day, and to have representation on all these different advisory committees across the federal government is a challenge for them. And we're seeing that as well. Our advisory committees are, 50 to 75% staff with tribal leadership, and it's it's a challenge. It's good that there are delegates to some of the tribes, and there are technical representatives, and we are getting that feedback. But it's definitely something we keep working on. And we are planning more of these. It just seems like we have more and more to do every day. But that's good. Building research capacity, that's another. How am I doing on time, Rand?
We're good.
Mm-hmm. That's another thing that I've been assigned. I know I keep saying I've been assigned this, that, and the other thing. Yeah, I've got a lot on my plate. So the research capacity is really something near and dear to me. So I serve on the Government Relations Committee for American Indian Science and Engineering Society and SACMAS, the Society for Advancement of Chippewas and Native Americans in Science. So many acronyms. ACs and SACMAS, and then I work with other universities, anybody who wants to reach out and increase Native representation in the sciences. That's really the key, I think. When I'm thinking, 10, 20 years down the road, what would I like to see? I'd like to see a lot more Native scientists. With that lived experience, doing that research, doing those interventions, doing those evaluations in the communities. That's what I would like to see. We don't have enough representation. We don't have enough PhDs. We don't have enough master's level scientists and epidemiologists. I mean, we just need to build that capacity. And not just that, we need to build the capacity around the IRBs as well, which is the former chair of the national IRB for IHS. It's something really important to me that I did back then. It's something that I want to do again from the NIH side. So it's important for tribes to have the folks with the technical and clinical knowledge and scientific knowledge there. But it's also important to have that expertise around the institutional review board so that they can protect participants in research, so that they can determine what the research is for their communities. We used to say at IHS, this is by and for tribal nations. And that's what we need to do, is we need to build that capacity so we can actually be by and for tribal nations. I just want to share some information on summer internships at NIH. So if anybody is interested, there's lots of information online, or you can just reach out to our office and we can provide lots of good information on the summer internships. It's just having that exposure to those labs at NIH, which is a really unique opportunity. And for those who have had that opportunity, I'm sure you can speak to that. It's awesome to see the look, the light that goes on when kids are exposed to these laboratories and these world-renowned researchers. It's really amazing to see that. See how excited I get about that. And we want that more Native kids to have that experience. That's what lights the fire, right? Once you have that experience, you're in a lab, you're working on something, and all of a sudden it's just bang, that's it, that's what I want to do. And then they just go. And all you have to do is support it. And they'll be there. They'll succeed. Oh, okay. I thought you were pulling me off stage. Thank you. So we actually had one of these interns in the throw office, and she worked out really well. She helped to write a paper and get that out. So expanding research and great photo ops too. Look at that. That's great. Look at all those young, beautiful faces. Love it. Expanding research. We're working with different offices. A common fund. I didn't know what a common fund was. I thought we all just kind of put our money in a pot. It was like for coffee or something. But it's actually in the office of the director at NIH, and we're working to incorporate tribal input to create programs to solve long-standing barriers to reducing health disparities. So what that means is, of course, we're having lots of conference calls with different people from different ICs to revamp these programs going forward. So we all know about NARCH, we know about ARENA, all these other acronyms that I probably couldn't define if you asked me to. But a lot of the programs are set up a certain way where either tribal colleges and universities or other academic institutions that serve primarily Native communities, they can't compete, right? Because you've got these institutions like Johns Hopkins and Harvard, and of course Boston University. Gotta give a shout out to BU. But they don't have that capacity, right? And it's hard to compete. So we're looking at programs and figuring out ways that make them more competitive, or looking at some of the qualifications to apply, so that we can make it so they can be more competitive and they can be funded. Because if you don't build that capacity, how are you ever going to compete for the R01s and be like these premier research institutions? So that's another thing that's really important to me is having that capacity at the university level and the tribal colleges, universities. I used to work with them too when I was at IHS. They're great, and that's where a lot of Native students get their starts. So why don't we develop that a little bit more so that they have really good, footing, they have really good training to move forward. Mm-hmm. And we're doing that across IC. So one IC might have the authority to do one thing, and another, has to focus on, neurological disorders and stroke. One has to do basic sciences. Well, how can we get them to work together with each of their missions to come up with something that can work for tribe? That's a lot of work. And this, gosh, that's a busy slide. I can't even all fit on there. Okay, well, this is just an example of during the vaccine development, and I wasn't there for this, but we had a couple of sites, and I can't even read it. So, but yeah, we provide support for that, and then we've had a couple of different calls with different entities that have been working on clinical trials, and trying to help them work through some of those challenges. But to get those set up was a huge lift, and thank goodness I wasn't there for that. But they're doing pretty well, and it says a lot. I wouldn't have thought that a tribal college or university or someone linked to could have done this 10 years ago. But we're making a lot of progress on that too. And kudos to those who step up and continue to work on this. Okay.
Q&A?
Gosh. Yeah, can you go forward one?
Too far?
I think so. Enhancing cultural competency, did we do that one?
There we go.
Oh, there we go. Traditional medicine. I talked about that earlier. That's another thing. You know, I grew up this way. I know a lot of folks grew up this way. So when I was still at Hopi, they NIH and Dr. Wilson and Dr. Bloom, they hosted this cultural competency, not cultural competency, traditional medicine engagement. So they brought together healers from all over the country and got some really good feedback from them. We're planning another one. When I was at IHS, I tried to set up a traditional medicines program there because I believed in it so much and it helped me so much. You know, being a veteran and, you know, after you get out of the military, certain things you need to deal with. Some tribes have those ceremonies, other tribes don't. But it's really helpful for veterans to reintegrate back into the community. So that's a really important thing that we're working on. It comes up daily, traditional medicine. And again, the ITech stuff, the traditional ecological knowledge, indigenous knowledge, we're trying to move that forward as well. So we've done a lot. I know that you all probably saw the Dr. Fauci and all the radio spots he did. A lot of consultations. We did a Native American Heritage Month with Dr. Don Warren. That was phenomenal. That was great. We've shared that across the ICs as well. And it's been really well received. But we also, could you put up the LinkedIn? Because I want to plug that.
Right here?
We launched our, keep going. The LinkedIn page is out. We've got about 400 or 500 followers, so we need more. One more. It's the last slide. Okay. And that's it. So that's our LinkedIn site. You can just search for THRO on LinkedIn and you'll find us. We put a lot of funding in that. We focus on funding opportunity announcements, internship opportunities, scholarships, anything that's relevant to what we do. We put out through the LinkedIn page and our website as well. But I think the LinkedIn is pretty timely. We try to get things out pretty quickly on LinkedIn. And I have my personal LinkedIn page, so whenever I put out on Throw, I put out on the page as well. And I've got 1,200 followers. So once Throw gets up to where I am, we'll be doing something. So all right, well, thank you very much. I appreciate your time. And I know that was a lot of information, so feel free to reach out.
So I'll speak loud. We have a question in the chat from our Zoom viewers. How is HEAL being enacted in the Black Hills? Not sure if you know precisely our Western South Dakota region, and then any connection to Project Recovery?
Yeah, that's a good question. I'm not sure. I know we rolled it out, across the country, nationwide, in South Dakota. I'm not sure. I know that there were folks from the Great Plains that were on the consultation call and gave lots of feedback. How is it being rolled out? Well, I think that's really still being worked on. And part of the consultation is getting the feedback from the community on how to improve how we roll it out next time. So, like I said, there's a lot of projects that are ongoing across the country. I think it's over 500. But we want to improve that, so it better meets the needs of tribal communities when we roll out new funding opportunity announcements.
There was one more question that asks, will this project be able to help set up and run intensive inpatient rescue recovery centers, which many of our people need, and will these centers be available on the reservations?
Well, NIH primarily funds research, and we get this question a lot too, because folks will come to NIH and say, can we, or they need to establish services. And NIH doesn't really do that. Like the missions slide showed, National Institutes of Health is focused primarily on research to improve those healthcare services, but not necessarily to actually deliver those healthcare services. So Indian Health Service has a number of programs that they've rolled out, that are in existence. I know I helped set up the methamphetamine suicide prevention initiative, which is now the Substance Abuse Services Program, I believe, SASP. And I know that other agencies like Indian Health Services have gotten funding for additional services. But NIH would, certainly, be responsible for addressing not the actual delivery of services, but the research to improve those services, or the research to figure out where those services would make the most sense. So, and I know that work is ongoing. So,
Any questions? Yeah, raise your hand.
I serve on the hospital, Monument Hospital IRB here in Rapid City. And we're getting, all of our research has gone to central IRBs. When I look at central IRBs, I don't see native representation on those IRBs for the most part, and I see no representation from the Great Plains area, and yet those studies are coming into our facilities and studying native people. Is there anything that you can do to ensure that natives are represented on those central IRBs?
Yeah, that's a good question. I'm not sure why it's getting elevated to the central and not being the local IRB record.
That's, well, because studies are scattered. There's one study and they'll be in numerous hospitals all over the United States.
Yeah, so it's a multi-site.
Right.
Okay, yeah, then I can see that. As far as the private IRBs, I'm not sure what we can do, but I know we've had discussions about that. How do we compel folks to have that representation? I don't have a good answer for you right now, but it's something that we've talked about. It's something that's important.
It's really important because they don't understand our culture. They can't even ask questions that can be answered from cultural people and give them the answers that they're looking for.
Right.
So it's really important to have that representation.
I guess my question would be, who's the non-scientific member on that IRB from the community? Because we're required to have a non-scientific member, right? I mean, I wonder who that person would be, and could they make that a native person from the community?
Sometimes the site or the central IRB does not even list who is on that IRB.
Wow,
So it's a problem.
that's a problem. Well, thank you for that question. It's a good point.
Okay, let's give Mose a round of applause.